I'm going to take a big step back and talk about gene expression profile testing, because that's what the Merlin assay is based on. Gene expression profile testing is a way to test a tumor, in this case, a primary melanoma that appears to be totally localized when we see the patient and examine them. But we know there's a risk of microscopic metastasis, in this case, particularly to the sentinel lymph node. And the gene expression profile is run on the tumor in an attempt to predict whether that tumor has a high risk of spreading to the lymph nodes or a low risk of spreading to the lymph nodes. Okay. In the case of this particular assay, to create it in the first place, what they did was took 754 consecutive patients who had a sentinel node biopsy at the Mayo Clinic and tested every one of those melanomas, looked at the genes and said, aha, here are 8 genes that discriminated between the ones that did or didn't have a sentinel node that turned out to be positive, seemed to be predictive. So they took that test, tried it in a few other sets of, here's some tumors where we know what happened after the fact. Yeah, seems to be predicting. Now let's see if we can establish this as a valuable test in a large prospective trial where nobody knows what the outcome of the test is. We don't use the test to predict, to specifically say, you have a sentinel node, you don't. We're going to test the test in a very rigorous fashion. We're not going to charge the patients. We're not going to tell the patients. We're not going to know what the test showed. We're going to test everybody, add it up at the end, and see how it worked. These gene expression profiles of one type or another have been around already for a while, but all of the major experts, guidelines, consensus committees have said we need this kind of large-scale testing to really determine, does it work? B, who does it work? In everybody or just a subset? And C, if it works, is it really cost effective? And so that's what we embarked on, that kind of a rigorous test to see what this gene expression profile-based test could do. We ended up with 1,686 patients who had a sentinel node biopsy and a successful gene expression profile test. 9 different melanoma centers around the country participated. And the test was successfully done in 97.7% of the tissue that was sent to the lab. So even after accounting for that, the ones that it didn't work in, we had 1,686 patients. What we found was, yes, the test was predictive in that if you had a high-risk test, you were much more likely to have a positive node than a low-risk test. Overall, in the entire 1,686 patient population, over 17% of the patients had a positive node. But then if you drill down and say, well, what did the test show for those patients? Well, what it said was if you had a positive, if you were low risk, you had a positive node 7% of the time, not 17%. And if you were high risk, you had a positive node close to 24% of the time, more than 3 times higher. About a third were low risk, a little more, 37%. About a third or 2/3 were high risk. So what do we conclude from that overall result? Well, clearly, as I said, it does have predictive ability. It does discriminate higher and lower. But is the low risk low enough to say never get a sentinel node? Probably not. Currently, in my practice, in many guidelines, we consider doing a sentinel node biopsy if there's even a 5% chance. And if it's a 5 to 10% chance, we consider that a gray zone. You don't have to do it every time, but we certainly consider it. And if it's greater than 10%, we want to recommend it most of the time in any patient who can tolerate the surgery. So if we get a result that's 7% or 6%, that doesn't get everybody off the hook, so to speak. But on the flip side, it allows us to start to have the conversation. Which threshold is right for which patient? Who are the people who really it's appropriate for a little bit higher threshold than 6 or 7%? Then let's not do the sentinel node unless it's greater than 10%. And certainly if it's 23%, let's definitely do it. So everybody getting this test? No. Thick melanomas getting this test? Really no, because almost all of the thick melanomas are high risk. Very few are low risk. And even the lower risk, because there's such a, that it's such a small number, and it's just not even worth dredging through all the high risk patients or the 1 or 2 who maybe don't need it. But if we are dealing with older patients, and in our study, for example, almost half the patients were over 65 or older, with a 6% risk for a low risk patient, and about an 18% risk, again, 3 times higher for a high risk. Actually, it's 21%. I'm sorry, it's more than 3 times higher, and nearly half of our older patients were low risk. So for many of our low risk patients, a 10% threshold is a bit more appropriate. And for those type of patients, this could be a test that could be very useful. And so this is the value of a very large, rigorous prospective evaluation. We can begin to really understand the performance of the test in a real life situation across multiple institutions where we had to take into account all the possible problems that could arise, all the uncertainty factors, all the variables, and now say, okay, how do we use this? And if we use it, how much money does it save us? Well, if we don't do a sentinel node biopsy on 30 or 40% of patients in any given population, not everybody, but say if we found 20 or 30% of older patients to not do a sentinel node biopsy on, we're going to save a lot of money, right? That sentinel node biopsy had a lot of costs, and that value offsets the cost of running the test in that population. So this kind of prospective trial is really important in helping us start that conversation, begin to drill down into who should or shouldn't have a test like this, and really ask, how do we use this best? How do we, how does it help us save money? More importantly, how does it help us benefit individual patients?